Good evening, good afternoon, and good morning. This is the 1655th day of continuous seminar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. T.AJAYAN. He's a professor at Trivandrum Homeopathy from Trivandrum. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, local language session in Malayalam. We are uploading the videos on the same on the very next day. But unfortunately, due to a ban, we were unable to upload the videos for some time, but we will upload the videos of the presentations in the coming week itself. And let me come to today's guest. As you all know, Professor T.AJAYAN is working as the professor at Department of Practice of Medicine, Sharda Krishna Homeopathic Medical College, Kulashekaram in Tamil Nadu. Very close to Kanyakumari. As you all know, the Kanyakumari is one of the place where most people visit in the southern part of India. And there is a homeopathic medical college named Sharda Krishna Homeopathic Medical College. It's one of the best in the world itself, I must say. So there we have a degree, post-graduation, and even PhD research work is also going. A lot of accreditation. They got a lot of accreditation in different subjects also. Anyway, Dr. AJAYAN has won the famous Dr. Jayaram Award from IHK. He is a national as well as an international faculty. Has presented different papers in different parts of the world as well as in India. And today, Doctor will be discussing about the second part of the summer complaints and its homeopathic management. The first session was already over in last week. So we proudly welcome you to the session, sir.
Thank you, sir. Is audible? Is an
Yes,
audible, sir?
Everything fine, sir.
PowerPoint is clear? PowerPoint is clear?
Yes, yes.
Okay. Good evening to all. I'm Dr. AJAYAN from India. It is a great pleasure to welcome you all to this seminar, all to this session. One, there is a role of homeopathy practitioners or role of homeopathy in managing the summer disease. Then first part is already over. That days we are discussing the few diseases, the summer diseases, especially we are concentrating the sunstroke, sun syncope, heat stroke, syncope, etc. But in all the system and related finding, the summer finding is there, summer disease finding is there. As a summer season brings your soaring temperature, it is also brings a host of the seasonal health concern. Then such as we are already discussing the heat stroke, heat syncope, then dehydration, sunburn, the prickly heat. Then today I would like to highlighting disorders, then again respiratory ailments. Everybody know the homeopathy with this holistic approach offers the effective remedies to help manage these conditions naturally and gently, and ensuring the faster recovery and prevention without side effect. Then today we will explore how the homeopathy practice can play a significant role in then while addressing the summer ailments, especially the maintaining their well-being and the strengthening the immunity through the safe and natural treatment. In this session, aims to provide an insight to the common summer related disease health issues, the homeopathic solution. Then just a minute, all are just please wait a minute. Just a minute. The technical issue, just please wait. Okay. Then again, second one is the preventive measures and its lifestyle tips. Then moreover, then a group of medicines and its practical application of the homeopathic remedies. In my knowledge, the last class we are discussing diarrhea. We are diarrhea already discussed. Next one is the cholera, the summer gastrointestinal disease is a cholera. The cholera is an acute secretory diarrhea caused by the toxigenic strain of Vibrio cholera. No, go into the details. Everybody know is characterized by severe, acute, large volume, watery diarrhea resulting in rapid dehydration and associated with a high mortality if not treated promptly. Then transmission occurs via the fecal-oral route. This one is an almost all the practitioners are aware, but it's a reflection in our knowledge. In pathogenesis, then always I would like to highlight in the pathogenesis because why? The homeopathy treatment is not based on the name of a disease, but our medicine prescription, our medicine always the pathogenesis, the mechanism based. We are studying the medicine is a little more effective to all the individuals. Plus, in addition to this, we are considered uncommon peculiar characteristic feature of the patient. Then one of the advantage of we are studying the pathogenesis and related the symptom and sign, we are easy to differentiate what is the common symptom and uncommon symptom. But only we are considered the disease diagnosis wise, we are so many difficulties we are facing to differentiate common and uncommon symptom. But in my personal opinion, the pathogenesis wise, we are discussing the signs and symptom. It will enter higher level. We are easy to differentiate the common and uncommon symptom. Therefore, the pathogenesis of cholera, first the injection of contaminated fatty water, the survival in stomach, the high infection dose record, the colonization of the small intestine, the production of the cholera toxin, activation of adenylate glycase, then it can leads to then transport disruption, then injection of then a massive water and electrolyte loss, that is sodium water loss from our body. They can cause us profuse watery diarrhea. The term here says is a rice watery diarrhea, rice water soup. Then that can lead to severe dehydration, then hypovolemia, hypokalemia, and finally hypovolemic shock, and followed by all the organs failure and finally death. Then here the key investigation and here based on the stage wise, the investigation also different. There are three main stages of the cholera: stage of evacuation, the stage of collapse, and the stage of recovery. The stage of evacuation means the patient is passed the stool more than 40 times per day. In that time, you must advise the stool culture, the rapid cholera dipstick test. Here, just to advise for the suppose we are confusion is here difficulties for the clinical diagnosis. For the final diagnosis, we are use the rapid cholera dipstick test. Then stool microscopy also help for you. Then serum electrolyte. Then here why we are advised the serum electrolyte. The reason is the 40 times the stool is passed, the definitely electrolyte imbalance is there. Because in sodium potassium is a direct linkage with our different electrical activity of our heart, especially then our important conductive system, or that is the firing from SA node into AV node into bundle of his, and the right and the left bundle branch. Therefore, then not only in cholera, any diarrheal diseases, then more amount of the water is lost, then immediately we are work out the electrolytes. Then interpretation, these investigation help for to work out the Vibrio cholerae infection. And then also this electrolyte imbalance also is highlighted in dehydration severity. Then that basis we are able to advise the general management. For example, if the dehydration is at severe, then aggressive rehydration, that is we are recommended oral ORS, or they are recommended in severe dehydration is there, we are advised identified what type of IV fluid is needed, that IV fluid we are recommended. The second stage is stage of collapse. That is a classical sign in clinical side, Sanganai, hollow cheek, then again abdomen, scaphoid abdomen, then subnormal temperature. These are the classical 5 features of stage of collapse. The blood test, then ABG, then arterial blood gas analysis, then again you are work out electrolytes. Then because the nowadays and cholera is not there, but recently then reported in certain districts is reported the cholera then last 6 months. Therefore, maybe then again this type of the disease are occurring. Therefore, we are aware about all these things. Therefore, is an included in summer disease. Then interpretation, all this investigation, blood test, the CBC, renal function, etc., ABG, electrolytes, we are workout is helpful to work out whether the hypokalemia or acidosis or renal failure and its severity we are assessed through this investigation. This investigation wise, just we are advised the right management in general management. Then what type of IV fluid is needed in emergency in stage of collapse, that is a ringer latrate and electrolyte replacement. Then if you are need, then maybe the patient is collapsed, then next stage is the patient is going to shock. If you are needed for the management of the collapse, sometimes you need intensive care unit. The intensive care unit always help for the monitoring the heart rate and rhythm of the heart, because already the electrolyte imbalance in sodium and potassium. If the sodium and potassium electrolyte imbalance is there, definitely the rhythm of the heart is altered. Therefore, monitor is placed. The 24 hours we are check the patient. Then stage of recovery, the blood pressure begins to rise. Then because the recovery stage, no need of, if needed, the another investigation you are advised. But in this stage, the nutritional assessment is very essential, because due to the different stages, maybe the nutrients are lost from our body. Then suppose the lost the nutrients, the related nutrients are just to supply for the supplementation. In recovery stage, we are just to assess the nutritional assessment is very essential one. Then suppose we are dehydration in mild, then just to continue the oral hydration. Then suppose that certain minerals like the nutrition as a part, that just to advise the zinc, and dietary recovery is recommended. Fluid and electrolyte then causes dehydration and cramps. The shock and audible.
Yes, yes. No, it's audible and visible. Some network
There is
problem.
an, sir.
Yes, sir. Yes, sir. Please go ahead.
Hello, Danesh, sir.
Yes, sir. Please go ahead, sir. We can hear you, sir.
There is an audible. Now it's
Yes,
audible.
sir. Yes, yes. Audible, sir. Please go ahead.
Okay, okay. Okay, next, as a part of the management, home care management, we are recommended ORS. The ORS solution, the World Health Organization recommended the ORS, that is a homemade solution, 1 liter of boiled water plus 6 teaspoonful for sugar plus half teaspoonful for salt. That way we are prepared an oral solution, ORS solution in our home, at a home. Drink then frequently, and it is small sip to compensate is the lost fluid. Then alternative, there is a recommended coconut water, buttermilk, the clear vegetable soup, then helps to restore the electrolyte. In my knowledge, then an outbreak of the cholera in our Kerala state, the days, then suppose then IV fluid is not available, the days they are used the coconut water for IV. The days, therefore the coconut water, the enriched amount of the sodium and potassium. The avoid caffeine, alcohol, the sugary drinks and carbonated beverages, this can be worsen the dehydration. Then for vomiting is subside. This the bread diet that is very essential for the maintain the nutrients. The bread means indicate rice, apple sauce, the toast, then boiled recommended spicy, fried and spicy and fried and high fiber food. Then the stage wise, that stage of evacuation, the three stages we are in pathogenesis, we are already evacuation. The one of the best medicine is diarrhea, cold sweat, extreme weakness, and collapse. Then a stage of collapse, that time everybody know then severe dehydration, electrolyte imbalance, the hypovolemic shock, the sign of hypovolemic shock. There is a recommended medicine is a camphor, the sudden prostration, cold body with an hot head, cyanotic face and absence of pulse and icy coldness of body. But in recovery stage, the recommended drug is China visionalis, that is weakness after diarrhea, bloating, loss of appetite, exertion after from the fluid loss. The stage of evacuation, then again you are think over other few drugs, then arsenic amalgam and China. The stage of collapse, then again you are think about China, gelsemium, medorrhina. Then during the time of the shock, the few drug carbovage, crotalus horridus, calcium bromatum, lorocirrus, etc. In stage of recovery, you are already discussed in addition to this China, you are just to think over. There is cholera after two. One is phosphoric acid, and second one is then sickle core. And camphora. There already say the important symptoms related to three drugs. These are the other drugs in related to cholera. In cholera during summer season, cuprum ars, another one more medicine. Just keep it in your mind. Cuprum ars. That bryonia is another medicine. Bryonia and phosphorus. In summer, then a number of drug is there. Out of this, then camphora, croton tiglia, phosphorus is to be considered. Then stage wise the dehydration, the mild dehydration, that is percentage of fluid lost from the body 3 to 5%. Only that amount of that means the mild dehydration. The clinical presentations are dry, mucous membrane, mild thirst, slightly reduced urine output. But that time the oral rehydration solution ORS, that is 50 ml per kilogram over 4 to 6 hours, you are only recommended. Then in moderate dehydration, that is a fluid loss is average 6 to 10%. Then clinical features in moderate dehydration including tachycardia, sunken eyes, reduced skin turgor, then oliguria, increased thirst, etc. That time recommended definitely need IV fluid. The time recommended IV fluid is ringer lactate or normal saline. That is a recommended dose. There is a 20 ml per kilogram per IV bolus. That is a recommended amount of IV fluid in moderate dehydration. Then severe dehydration is greater than 10%. The fluid loss greater than 10%. That time definitely hypotension, the sign of hypotension like weak pulse, lethargy, anuria, cold extremities. That time also the crystalloid, the lactate or normal saline is recommended. But instead of in moderate dehydration 20 ml, here the 30 ml per kilogram per IV bolus we are recommended. But the rapid infusion is recommended, not like the moderate dehydration. That is rapid infusion over 30 minutes, repeat if it's required. In shock, in hypovolemia, is greater than, that is fluid loss, or more than 15%. In severe hypotension, that time the crystalloid IV fluid is then 20 to 40 ml per kilogram per IV bolus is recommended rapid infusion like our severe dehydration. That is then hypotonic. All the IV fluid is we are classified into two. Then hypotonic and isotonic. That is a working of generally we are worked out this one the IV fluid is and how to work in hypotension. We are need lower osmolarities and recommended needed. Here recommended hypotonic fluid was the recommended hypertonic. The equal osmolarity is needed. They are recommended then isotonic. So just a minute, an emergency call from my college and hospital. Therefore, I am attending. Nagaswara, I am in a class. Please call after an hour. Okay. Sorry, I will continue. This is a composition. I am not going to the details, but if you are needed, the recommended then IV infusion. Normal saline or ringer lactate is insufficient. The next we are discussing the vector-borne diseases. You know the vector-borne diseases is in mosquito bite disorders. Then first and second one is the malaria and third one is the dengue. That time a common question we are raising. Then these are the diseases also common in rainy season. Why this prevalence in summer season? The reasons are, one is the mosquito thrive in warm, humid climate than the cold climate. That is the reason why is included under summer disease, summer vector-borne disease. The bite frequency is more due to habit of wearing light clothes than during the summer. Then why I am focusing these things? As a part of the general management, also we are recommended all these things. The common in summer season, almost all the people are wearing the light clothes. Therefore, the bite frequency is more. Therefore, the more chance to these infections than chikungunya or malaria or dengue fever. Then third reason, the stagnation of water body from the partial drying up in early summer. These are the reasons why the vector-borne diseases common in summer season, especially chikungunya, malaria, and dengue fever. The first in the chikungunya is the arthropathy, that is fever and generalized hemorrhage and CNS symptoms. The sudden onset of the sun important classical symptom of chikungunya. The main vector of this virus is an Aedes aegypti. This is a pathogenesis. Then chikungunya virus infection begins when an infected mosquito bites the human and the virus is introduced into the skin and the bloodstream. And then the virus is replicated inside the fibroblasts of the dermis. Then later is an enter the viral replication. The virus replication occurs in the targeted tissue. Mainly the target tissue in chikungunya is in muscle, joint, and skin. But then certain internal organs are also that considered as a target organ, that is liver and spleen. After that, these inflammatory cells are recruited to the infected tissues and finally is affected the joints, including that our joint, wrist, elbow, the knees, ankle, and the toes. Then all these areas, it shows the inflammatory response and simultaneously the virus replication. Then symptom of our chikungunya, the incubation period is 2 to 10 days. Then fever is often with a saddleback pattern of the severe arthralgia, then associated with the chilliness. Is migratory polyarthritis mainly affect the small joints, like our rheumatoid arthritis, but it's an acute in nature. Rheumatoid arthritis is chronic in nature. Migraine is seen in rheumatic fever, rheumatic arthritis, also the migrating polyarthritis. The rash is most intense on the trunk and lip and may desquamated. And maternal fetal transmission has been reported and in some cases has led to fetal deaths. There is an epidemic in nature, almost cases epidemic in nature. Therefore, not only a particular individual is not very rarely affecting. Then clinical features, the high rise of temperature exceeding more than 102 degree Fahrenheit associated with the severe joint pain and rash. The time investigation, in addition to this CBC, the RT-PCR test. The RT-PCR test is helpful to detect the RNA virus. Then in differential diagnosis, we are consider the dengue. The dengue cases and investigation include then NS1. NS1, then very first day onwards, the specific antigen is increased. Non-specific antigen is increased in the blood. Very first day we are able to diagnose. Then later, the dengue case, IgM and IgG test. Then in clinical features, the fever resolved, joint pain persists. Then just advise a chikungunya IgM ELISA test. Is an indicated that very recent IgM always indicated antibodies and indicated the recent infection. But in all the cases, because it's a chance for affecting the vital organ, therefore LFT is must. Then in so there's slight elevation of AST and ALT. Then alanine transaminase and glutamine transaminase is increased in blood. Then CRP also just elevated. Then not too much like our vital infection, the CRP is not rise, but CRP is rise. The persistent polyarthritis and fatigue, the muscle weakness, then instead of that means then indication means the patient is the past the exposure to chikungunya. That you are doubtful cases, you must advise chikungunya IgG, ELISA, not IgM. The IgM, you are advised the recent infection. You are suspected a recent infection, you must advise IgM, ELISA, chikungunya. But here IgG you are recommended. Then for the differential diagnosis, you must consider rheumatoid factor RS. In addition to this anti-CCP, why we are recommended? Because then it's an affected the small joints, the like rheumatoid arthritis. Then prevention, there is a live attenuated vaccine and anti-mosquito measures and mosquito repellent is an advice for the management of for the prevention of the disease. And homeopathic perspective, in homeopathic perspective, there's management. Then severe fever, the severe bone pain, stiffness of joint and chill and shivers and headache. And just you consider the medicine. There is a polyporous pinicola, is one of the drugs we are widely used. Then Epitorium perfoliatum, intense bone pain, it's like bone break. Then high rise of fever and chill, soreness of muscle. The Bryonia alba is a pain aggravated by the movement and relieved by rest. Rest stops, joint pain worse, rest from better by movement. Then another drug, another medicine you are considering Actia spicata, the pain in small joint, swelling or affected joints. These 5 drugs that just be considered for the management of chikungunya. Then stage wise, we are just to think the acute febrile phase. If you are in very first phase and viral entry, early infection, just think over ferrum phos. That is an early inflammatory stage. And inflammation before exudation sets in, that time we are recommended ferrum phos. Then acute febrile phase, that means within 3 to 5 days, naconite and belladonna, just you think. The severe muscle and joint pain, the restox to be considered. Then the blood vessel, the capillary leakage plus then vascular inflammation, just think over China originalis. Then the skin rashes, it will producing immune hypersensitivity, Apis mellifica. In chronic arthritis and post-viral fatigue, the just you consider medicine is the caustic. Then post chikungunya cases, just you remember that's drug caustic. Then other drug and relationship with the rubric of chikungunya fever remittent. Then rubric is fever remittent. The joint pain undefined, the lower limb ankle pain, eruption rash, the skin eruption rash, papular, the joint pain undefined. Then so many medicine in our repertory. Then next we are discussing dengue. Then every year that is reported the dengue fever, even in our day-to-day practice nowadays is a common. Then in my practice, then we are doubtful of a dengue cases and almost their presentation is like this. The retroorbital pain, the fever associated with the retroorbital pain. And most of the cases, that 70 to 80% of cases, we are able to diagnose the case of dengue. Then clinical presentations are like, is a classical dengue fever, dengue hemorrhagic fever without shock, then dengue hemorrhage with shock. There are 4 viruses and agents, dengue virus 1, 2, 3, and 4. Then here the vector is Aedes aegypti and as well as Aedes albopictus. These are the vector is and causage for the dengue fever. These are epidemiology wise is reported, almost the cases are reported in July, August, and September and October. So the season is an dengue fever outbreak is there. But nowadays in clinical practice, if the fever is not subside, and previously I say the characteristic of retroorbital pain is there, just you advise NS1, then very first day itself we are able to diagnose the dengue fever. Very first day. The dengue virus infection, a symptomatic infection is symptomatic, asymptomatic and symptomatic. Then already I say the symptomatic infection, undifferentiated, the fever, that is viral syndrome, then dengue fever, then dengue, the with the hemorrhage or without hemorrhage, maybe the presentation is there. Then dengue hemorrhagic fever with the shock. There is a reason of dengue shock is that is a plasma leakage syndrome. The maybe in clinical side, even the plasma leakage is not shock. The classical, the presentation in dengue shock syndrome. The dengue shock syndrome is there is considered as a dengue hemorrhagic fever. Then without or with the milder is a dengue fever, classical dengue fever. Then a mosquito is taking the blood meal from the person with acute dengue. That is enriched in the salivary gland and also is living the midgut. Then virus insect in midgut and eventually travel to the salivary gland of the mosquito. Then it is an after biting is reached. One mosquito can infect the several humans at a time. There is one type of spread. Another one is intrinsic incubation. The one set of the symptom usually within 4 to 7 days. It's the life cycle of the mosquito. The pathophysiology, after the infection, the Egypti bite, the virus penetrates the skin, then it is replicated inside the Langerhans cell. If it is replicating inside the Langerhans cell is and affect the immunity of the skin, then this Langerhans cell release the interferon. This interferon, Langerhans system to make the immune system is alert, then it's result in viremia. Then high level of virus in the bloodstream, that time in viremia, the high amount of the virus is seen in the bloodstream. Is an activation of immune response. It can liberate the increased lymphocyte. Then that is lymphocytic leukocytosis. Then it is will gradually then leukocytopenia, neutrophilic leukocytopenia. After is the release of the pyrogen causes the fever and increase the blood pressure in the vessels, causes rashes. That time here says the classical dengue fever. Then 3 clinical variants is there: dengue fever, dengue hemorrhagic, dengue shock syndrome. The symptoms are like this, and headache is retroorbital pain. The classical presentation of the dengue fever. Then acute febrile illness with or without more on following: arthralgia, bone pain, rash. But in dengue hemorrhagic fever is a little more lasting, the 2 to 7 days. The tendency for hemorrhage, maybe the spontaneous bleeding, is a positive tourniquet test is an helpful to tendency of bleeding. Then another other signs like then indication of the plasma leakage, the time, then pleural edema, then pulmonary edema, ascites, etc. The time you are just to think pathogenesis is then escape of the plasma leakage. In our blood, 80% is the plasma. But dengue shock syndrome means then dengue hemorrhagic fever plus, that means already discussed the dengue hemorrhagic fever, then plus the evidence of circulatory failure, rapid weakness, rapid pulse, then hypotension of for age, very narrow pulse pressure, the pulse of systolic and diastolic pressure, the restlessness, etc. In dengue fever, then leukopenia, the normally is WBC less than 5,000. Then thrombocytopenia, again, the thrombocyte count, that is, the platelet count is less than 1 lakh. The raised hematocrit values, then increase serum IgG level, then increase IgM. There is a dengue IgG and a dengue IgM. But in hemorrhagic fever, that is platelet count is again less here compared to dengue fever is less than 1 lakh. The sometimes is reaching 50,000. Or raised hematocrit values, then hypoproteinemia, albuminemia. Then in blood, then albumin level, the protein, the lower molecular protein, the albumin level is decreased. But in dengue shock syndrome, high hematocrit value, marked thrombocytopenia, then low ESR is differentiating from the dengue shock syndrome from septic shock. That is a very low ESR. The below 10 mm. That means why the ESR level is increased, because in here raised hematocrit value. In homeopathic side management, then a dengue fever, just you remember the Epitorium, Rustox and Arsenicum. And dengue hemorrhagic fever, just you think over Hamamelis, phosphorus and Caraca papaya. They improve the platelet count in the Caraca papaya. Phosphorus, then one more drug in dengue hemorrhagic fever, arnica, is to be considered arnica. There is Hamamelis is a capillary which causes undue weakness. The dengue shock syndrome, just you remember the drug medicine Epis mellifica. The Epis mellifica in drug medicinal pathology, that is a plasma leak, shock, and the serous effusion. All these features are similar to our Epis mellifica. In general management, dengue fever, monitor the level of consciousness, platelet count, hematocrit value, BP. If you are needed IV fluid, then always just you work out the hematocrit values, urine output, then advice for rest. But the general management side in dengue hemorrhagic fever and dengue shock syndrome, the little more attention is needed for the management of these both conditions. Then according to the blood values only, we are recommended the general management. Then our goal is that just to reduce the high temperature, high fever, the promote oral feeding, then regularly check the CBC every day, consider admitting the high risk patient, IV fluid is necessary just after the checking the vital sign, plus the work out the hematocrit values and the urine output. That basis we are recommended IV fluid in the dengue hemorrhagic fever, because it will always we are recommended IV fluid is the normal saline. The normal saline almost the equilibrium in relationship with our blood. Therefore, we are recommended IV in our normal saline. But depend upon the variation or biochemical variation and the nutrients, here the change the IV fluid, no issue. But commonly they are used the normal saline. Then dengue shock syndrome definitely need IV infusion. The bolus is around 20 ml per kilogram for 0.9% of saline, normal saline solution. Should be give every 15 minutes until the pulse pressure is at least 30 Hg. The pulse pressure, I say, that is the goal we are attained for the management of the dengue fever. That means the systolic and diastolic difference always maintain in 30. Then remaining the 10 minutes remaining. I'll continue. The malaria. Malaria is a parasitic infection is transmitted by the Anopheles mosquito that leads to an acute life-threatening disease. It can cause a Anopheles mosquito. The Plasmodium parasite has multi-stage lifestyle which leads to characteristic the cyclical fevers. Commonly is a seasonal infection. Is a transmission. The agent in 4 species. Everybody know the Plasmodium falciparum, Plasmodium vivax, Plasmodium ovoid. That is a classical Plasmodium malaria. Is very less common. The Plasmodium knowlesi is a parasite of the macaque monkeys, now recognized to cause occasional illness. It's very rare one, knowlesi, but Plasmodium falciparum, it is a severe illness. It will producing the severe illness is a very common one, Plasmodium falciparum. Then vivax also severe illness is an uncommon. Then Plasmodium ovoid is very less common. It's a lifestyle of the malarial parasite. Then falciparum, its incubation period is a common malaria, is a 9 to 14 days. But vivax is an 18 to 70 days. Then cotton type is an 18 to 40 days. Then ovoid, that is a 16 to 18 days of malaria. This is the incubation period of variant type of malaria, malarial fever. The bite of an infected mosquito is a parasite start reproducing in the liver. Then some parasite remaining the dominant for the years before becoming activated. Then it is enter into the bloodstream, the further reproduction occurs. Then it will in bloodstream, it will enter inside the red blood cells. Then parasite for the enter in the red blood cell for the reproduction. Then after that, the cyclo red blood cells and infection, it will destruct the cells. The beta associated with the followed by that is constitutional symptoms like fever and chill. Then finally is a dormant version of the parasite is ingested by another parasite. There is a life cycle, normal life cycle. It's a pathophysiology. Then what is the, then here in pathophysiology we are think over what is the reason for the anemia. Then anemia is due to then after the phagocytis, then infected RBC and already says the parasite is enriched in the RBC. Then RBC is an adhere to the blood vessels, obstruct the blood flow, then can causes and finally it will causes the phagocytosis. If the phagocytosis is there, there is a also followed by hemolysis. In hemolysis associated with our internal reservoir of blood, the structures like spleen and the liver is enlarged. Is due to the excessive the hemolysis and anemia is developed. Then hemolysis that can lead to the renal failure. Therefore, we are carefully treated our malaria cases because it's directly affecting the blood cell RBC. If an RBC is affected, that definitely it will produce the severe problems like anemia, renal failure, etc. But in after it's affecting the RBC, it will causes another pathogenesis. It will produce in tissue hypoxia that can causes obstruct the blood flow. This tissue hypoxia and obstruction of the blood flow, it can causes chance for the cerebral edema, pulmonary edema is most commonly seen in the cerebral malaria. This is just I say about the pathogenesis of our malaria. There are 3 stages in clinical features: cold stage, hot stage, and sweating stage. In cold stage, the lassitude, headache, nausea, and chillness. But in this cold stage, the temperature is raised to 39 to 41 degrees centigrade, associated with the headache. The skin shows very cold. It's an early part of this stage, but it's later it become hot. But in cold stage, the cold then affected the early part of this stage. The skin is always cold. The pulse is always rapid and weak. But the cold stage is lasts for only 15 to 60 minutes. That means average maximum that is an extent up to 30 to 45 minutes. But hot stage, that clinical features is little bit different. Feeling of burning, hot and patient cause for the clothes, and intense but nausea diminishes. Then hot, dry, and touch the skin while touching it is very hot, and pulse is always full bounded pulse, and the respiration is rapid. It is lasts for 2 to 6 hours. That is the hot stage. But in the sweating stage, the fever comes to normal, maybe profuse sweating. The temperature maybe drops rapidly to normal in sweating stage. That is a fever always intermittent in nature. Intermittent is like this cotton, tertian, quotidian types. That means the 4 hour, then 6 hours, that time only that is increased and is returned to the normal. That is a intermittent fever. Then skin is always the cold and moisture, but the pulse is very slow. That time is lasts for 2 to 4 hours. In clinical phases, paroxysm, the sudden attack of fever, chill, sweat every 24, the 48 to 72 hours, depend upon the parasite species. I already says cotton, tertian, quotidian type of fever. Maybe there is that fever, chill, and sweat in every 24 hours, or sometimes in within 48 hours. But sometimes it will be the Pellepstin type of fever. Then Pellepstin type of fever is classically we are seen in the lymphoma, but that is a long period the fever is not there, and another a long period the fever is present. That is also a type of intermittent nature. Therefore, we are saying it's a Pellepstin type of fever. Then associated features had malaise, the gastrointestinal distress, upper respiratory symptom, muscle ache, etc. In severe malaria, it's an affected the internal vital organ, jaundice, the dark urine, confusion, seizure, and coma. Investigation. These are the malarial fever. In severe malaria, then electrolyte is be checked. Then it may be indirect hyperbilirubinemia. That because it's an irritate the erythrocytes. Therefore, indirect hyperbilirubinemia. That is in Vandenberg reaction. In blood Vandenberg reaction, indirect is positive. The severe thrombocytopenia, coagulation, the panel may be revealed coagulopathy. Then arterial blood gas should be considered. Then maybe for the differential diagnosis need the lumbar puncture. That depend upon the presentation wise that just your investigations are changed. Then in homeopathic perspective, in malarial fever, chininum sulfuricum. It is widely used in the three stages we are already discussed. Then out of this first stage is the cold stage. The chininum sulfuricum in use in cold stage, cinchona in heat stage, and bullets is you are widely used for the malaria in sweat stage. The eucalyptus another medicine. The malarial fever associated with the gastrointestinal catarrh is there. Just you remember eucalyptus. In severe malaria, then hypertrophy, injuries from liver, the painful to touch after malaria, just we consider arsenicum album. Gelsemium is an associated malaria associated with the meningitis. Then cephalgia from malaria, there is a recommended medicine is the gelsemium. Always just to remember this medicine, gelsemium. The terbinthine in associated with the malaria associated with the nephritis.
Okay.
There is a nephritis malaria.
Okay.
Just be conscious. Is a terbinth.
Okay,
Okay,
sir.
the time is over.
Yes, sir. Yes, sir.
But
It's a very good session indeed. And since there is no time for discussion, I invite Dr. Beatrice Krishna to say a vote of thanks as well as your comment to the session. Please, Anju.
Yes, this is Dr. Beatrix and Dr. Ayan. It was a very, very interesting session. Thank you so much. And also, I'm at the moment in Argentina, in Buenos Aires, and we also have a lot of dengue fever here. So your advice is very valuable. Thank you so much. It was a pleasure to see you again. And thank you very much, Dr. Danesh, and all the group of Ifph. And yes, let's continue with our work. And I'm here for translation of the Spanish organon with Dr. Gustavo Pira, which is very nice.
thank you, ma'am. Thank you.
Thank you, Dr. Beatrice and Professor Ajayan and those who attend the session. Tomorrow we will have a session from Dr. Prakash Rao, and Dr. will be discussing about genus epidemicus and homeopathy. Thank you all. Good night. Hope all of you will join tomorrow at the same time, using the same time, and using the same thing link tomorrow also. It's over to Dr. Bindiraj for the Malayalam session. Thank you all.